Good morning. Thank you very much for joining us in this dry eye symposium. So to finish this up, we're going to speak a little bit about management right now, about therapeutics. This is my disclosures, and I'd like to start by saying once again just about the non-relevant facts, things that my colleagues have been said to you already, but I'd like to stress the fact that dry eye, no matter what kind of dry eye we are dealing with, there is always inflammation in all of them. And this has been clearly demonstrated not just by us, this is all our publications in which we found inflammation, but by many other authors. So it really makes this phrase true, that if you look for inflammation, you will find it. Let's speak now about the general therapeutic scheme, and the scheme that we follow at present has been established by these bodies, the American Academy of Ophthalmology, the International Task Force, in the 2007 and the most recent report from the International Dry Eye Workshop. Right now, we treat our patients depending upon the level of inflammation, the level of clinical activity they have, and these levels are 4 so far. And as you see here, level 1 is mainly just symptomatic patients. Level 2, we start seeing, an unstable tear film, and this is very important. Level 2, we start to see corneal staining, conjunctival staining, and in level 3 and 4, the staining of the ocular surface is greater, and in general, the ocular surface is suffering much more. So in these 4 levels, this is the therapeutic established for each one. And let me add here some remarks that I would like to make in red color. So in the level 1, we use educational and environmental modification, and this is very important. And also it is being demonstrated in a very large amount of people that omega-3 intake might actually get these patients better. We need to go through all the medications, not only systemic medications, but topical medication that patients are getting, and just get rid of anything that is not really necessary. Of course, we'll start using artificial tears, gels, ointments. There are a big amount of those in the market already. I can't tell you how important lid hygiene, adequately done and routinely done it is. And this must have to be explained many times, but in long term, this is very important to have a healthier lipid layer, and this will help actually to tolerate better the drugs that I will tell you about later. So here in the level 2, we start using anti-inflammatory therapy, and right now this is established level, but in the future we might start to using it here. All these depend on how available these therapies are. Tetracyclines, as you know, are very useful long-term. Secretagogues, we really don't have anything in Europe. Punta class are very much in question. I particularly don't use them. Then from here, we can use autologous serum, the platelet-rich factors, or platelet factors enriching the serum. We use this a lot in Europe. I know this is less used in the United States. And we can actually use systemic medications in a level 4. Let's concentrate our talk in the anti-inflammatory therapies from this point. And this is what we have all around the world, although, as you know, many of the drugs that I'm going to speak about very briefly are not available in Europe, are not everywhere. First, we all have steroids available as anti-inflammatory agents, and actually this paper shows and this paper gathered the opinion of many ophthalmologists all around the world, but I like to show this here because most of these ophthalmologists were from Europe, and the question was, what drugs you use in your patients, in your dry eye patients? So the answer was that the main drugs used were actually, as you see here, topical steroids, fluoromethalone and loteprednol among them, cyclosporine, and autologous serum eye drops. So these are the steroids that we might have available. We don't have, I mean, of course, methylprednisolone is compounded, but it's not that very much used. Loteprednol is widely available in the States. It's not available in Spain, and I don't think it is available in any other European country. I may be wrong about that. We have in Spain and in several other countries preservative-free dexamethasone. And I would like to show you data in this corticosteroid just because we did a nice study, and it is one of the corticosteroids that we use most because it doesn't penetrate, doesn't elevate IOP as long as you use it, of course, short term. So we did this randomized controlled clinical trial, and we measure all of our patients' clinical tests and all the tears that we took in a nice environment, in this environmental chamber. And we also put patients under circadian stress environment. I will tell you in a minute about this. I'm showing you as an example of the results just this graph, which deals with corneal staining in the several visits. There are many more data, but I'm just showing you this because I think it represents what we found in this trial. So in visit 1, we gave patients either fluoromethalone in the black lines, or it's placebo, gray line, and for 21 days, 4 times a day. And as you can see, corneal staining decreased only in patients treated with the steroid and not with the preservative, I mean with the vehicle. And here we entered these patients into this desiccating stress environment that you see here, which mainly consists of low humidity and airflow, which could be the equivalent of the environment that we're having here, airflow, low humidity. And as you can see, patients who were under this drug were kind of protected because the corneal staining remained very low. This is actually quite normal, didn't increase. Whereas patients having just taken the vehicle, the corneal staining increased. So the eyes were more stained, the cornea was more stained. In addition, the eyes were redder and the BUT was shorter. So we actually evaluated them 1 day after to see what the effect was 1 day after. And as you see here, patients under the drug still had no staining at all. Patients who were treated with vehicle remained with this increased staining. So this clearly showed that this drug, and again, we chose this drug just because we wanted to know whether something could be able to get patients to this environmental desiccating stress in better conditions as a proof of concept. So this drug made patients better and also made patients stand better these desiccating stress conditions. We actually also took tears from both eyes in these different time points. One eye was sent to our colleagues in the University of Tampere, where they are doing proteomics. This is not yet published. And with the other eye, we took also 2 microliters of tears and did Luminex measuring 15 cytokines. And what we found, we have many, many data, but to make a very long story short, we could define severity biomarkers in visit 1 because mild to moderate patients were included, and these molecules were showing a high correlation with clinical signs, interferon gamma aromatase and MMP9. This molecule, epidermal growth factor, was the greatest marker for disease activity defined as the increase in inflammation that we saw in these 2 hours. And as therapeutic marker of this drug specifically was interleukin-2. And any other drug we might have another biomarker. Cyclosporin might have another biomarker. Lifitegrast may have another biomarker. That will vary depending upon the drug you're testing. So with this, we established that steroids were, and as you know, they are very much used as short-term therapy. We need long-term therapy. And for that, we have topical cyclosporin. All of you know that the mechanism of action has been said many years ago because we have, and when I say we have, I mean really they have, because as you know, in Europe, we don't have this 0.5% topical cyclosporin. Although we use it, we get it from countries where it is available. We get it as a compound preparation, but we have been using this for many years too. There is now in Europe, for the last 2 months in some countries, not yet in Spain, this another topical cyclosporine 1%, and we really don't have much experience of that yet. And again, it's not available everywhere yet. So cyclosporine showed in the clinical trials mainly an increased Schirmer test, and then some other articles, and there are many published articles in cyclosporine, have shown improving symptoms, decreasing staining, increasing global cell density, and with this we will improve the quality of the mucus layer and a decreased artificial tear usage. What about topical tacrolimus? Tacrolimus is not available anywhere, and I don't think it will ever be, but we again use it as a compounded therapy. It's more potent than cyclosporine. The only thing that we have available is the skin ointment. It can be used, applied to the eyelids, but it can also be used, and there are enough literature about that, that it's safe to put it inside the eye, and also we can have it compounded as low as 0.01% eye drops. Let's speak a little bit about topical leafetic grass, which is what we're here today. Leafetic grass, actually the molecules that leafetic grass impact is ICANN1, and there are studies from 15 years, actually by previous speaker, Dr. Stern, showing that the conjunctiva of dry eye patients stained heavily for ICANN1. And actually in this very nice paper, 2 years later, they showed that dry eye patients, no matter whether they were Sjogren or not Sjogren, had an increased staining of ICANN1, not just in the epithelium of the conjunctiva you see here or here, but also in the infiltrating cells that you might see here better. So the infiltrating lymphocytes were highlighted for ICANN1, and in the epithelial that you see here. And here you can see that the expression of messenger RNA was actually also increased in the epithelium, in the infiltrating lymphocytes in the conjunctiva, and in the accessory lacrimal gland. So summary of this is that ICANN1 is highly or more highly expressed in dry eye conjunctival tissues from humans, patients. Leafetic grass is a leukocyte function antigen 1 antagonist. It blocks the binding of ICANN1 to LFA1, then interrupting the so-called immunological synapse, the inflammatory cycle. It is approved in the United States, I think, for a year now, as a 5% topical solution. And the clinical trials Shire performed showed that not only corneal and conjunctival staining signs were improved, but also symptoms, and it showed a good tolerance up to, I think it was a year. So it's a safe drug. I'm sorry, I'm going backwards. So as summary of the challenges that we have to manage dry eye right now, what we need to do, starting by the beginning, to talk to patients a lot, change their lifestyle, do some environmental dietary therapy. We need to, again, go into the list of medications, remove everything that is not strictly necessary. Of course, artificial tears will have to be indicated from the very beginning. Autologous serum and derivatives are useful, but not indicated in every type of dry eye, and it is my belief that we need to deal with inflammation first. Tear drainage blockage, the Puntum Plus, are controversial, and I'm not going into that today. Doxycycline is a drug that is very useful when you use long-term oral, especially for meibomian gland disease, meibomitis, and also when we have corneal problems. Steroids, as I said, are always very useful, but of course, all of you know that steroids have to be used short-term, never long-term. So as long-term therapy, anti-inflammatory therapy, we have cyclosporine, although not universally available yet. We have topical leafetic grass, only available in the States right now, hopefully in the next future here too. And sometimes we have to use systemic immunosuppressants. But the truth is that right now, our challenge is that we don't have much or nothing actually in the pharmacies available to send our patients to buy a prescription drug. We have to explain all the process of how to get cyclosporine in the future, how to get all the drugs. But as up today, at least in this country and in many others in Europe, there's nothing available as long-term anti-inflammatory therapy. So we do actually need, therapies for our patients. Thank you very much. This is my collaborators, and this is actually the group that did all the job. And I'd like to thank all of my collaborators, especially Michael Stern. Thank you.